This mini lecture is going to cover fungal infections as well as parasites. And these are the common ones that you'll probably see in primary care. When we think of fungal infections, we use the term as dermatophytes, which is your tinea. And these are superficial skin infections caused predominantly by three main fungal species. So you have the microsporum, the epidermophyton, as well as the trichophyton. The transmission occurs primarily through direct contact with an infected person or an animal, such as a cat or a dog. And there could be other modes of transmission too, where there could be asymptomatic carriers who can infect family members and intimate friends, or also a contact with us with the soil, and that would be more of a fungal species. Although this route of transmission is not really is kind of controversial, they're saying that if you do share hats or combs, that those fomites can be implicated in spreading those tinea infections. And it is not uncommon to find more than one infection on one patient. The environmental and the host factors do play an important role in developing these. So favorable environments, that increase the chance, such as heat or moisture, poor air circulation, broken skin, broken hair. Women have a tendency sometimes to get a fungal infection under their artificial nails if they get moisture underneath those areas. The first one we talk about just very briefly is your tinea capitis, and this is usually seen in children. Very rarely do you see it in adults, and it's ringworm of the scalp. And we're not going to really get into that one because of the fact that we don't see it in adults, other than just to let you know that there usually are no systemic symptoms such as fever or anything related to that. And the typical patient that has tinea capitis usually has like a black dot, and it presents with a painless, patchy alopecia. So the parents will bring them in because they're missing a patch of hair on their head. The tinea corporis is the ringworm of the body, and that is seen in all ages. The tinea corporis, the typical patient will report a history of having a kind of a red, round, elevated, itchy lesion that grows in size, and it starts to clear in the center, so it does have the shape of a ringworm. Sometime another family member may have had the same infection. Some patients report a history of prior infection, and you have to ask them if any of their animals, such as their cats or dogs, have any missing hair or anything on their body, or if they've seen any lesions, because it's very common for these animals to have that type of fungus and then transmit it. When you're thinking about the corporis, it can occur in any age group, as I said, and usually the patient will come in because the lesion's starting to get bigger. Some of them have numerous lesions, and they just get very itchy. When we're thinking about the tinea curis, this is typical patient is usually an obese adult male who complains of a rash on the groin, and it's spreading to the medial inner aspect of his upper thigh. This is usually not associated with itching at this time. It is more common in men in the summer or in the during warm weather. And the typical lesion is usually round to a half a circle. And as I said, it does not, it just goes into the intermedial upper thigh, but it does not go to the scrotum. In contrast, if you think about the scrotal involvement, if somebody has candidal intertriga, which we're going to talk about also, that can infect not only the groin and the thigh, but also the penis as well as the scrotum. So the color of the lesion really is depending on whether it's chronic or it's acute, and it could be bright red, it could be a dull discoloration, and it could also be macerated from having an infection there also. When you think about the treatment for a lot of these, the corpus as well as the curis, there's a lot of topical medications that you can give for these. So you can give the miconazole creams, the chlorotrimazole creams, a lotrazone, which is a combination of betamethasone and clotrimazole, as well as Lamisil. And there's just numerous amounts of medications that you can use. But when you do have to think about treating somebody with orals, it would be the Sporanox or the Lamisil PO pills, and you would have to check their liver before you start the treatment, get the results back, and don't start the treatment until you do. And during the treatment, and then after the treatment has completed, you'll want to do another another liver function test on them. Another tinea that we see pretty frequently is tinea pedis. And tinea pedis is the typical patient usually is a male teenager athlete or an adult who comes to the clinic and they complain of having athlete's feet. They have a very strong foot odor, and they do not usually have pain with this infection unless it gets infected with a bacteria. And this is where someone can get a cellulitis. They report areas of a macerated, soft, white skin between the toes. Some patients will complain of concurrent infections on the hand, on the body, on the toenails, but it's usually asymptomatic, although sometimes they do complain of that secondary infection. The infection usually starts in the third or the fourth interdigital web space, and it spreads to all the toes and the soles. So that's where it kind of hits, is right in those two areas. And if it becomes infected with bacteria, it would usually be a Staphylococcus aureus bacteria, and a very small tender cellulitis can start to occur in that web space. Another presentation is with a dermatophytid, and there's an acute id eruption, we call it, which is caused by hypersensitivity reaction to the fungus. And that id eruption presents as vesicles on the side of the fingers and the palms of the hands. And these vesicles do contain a fungus but are sterile. And they may not be aware that they even have a tinea pedis infection. And then the last one we're going to talk about is onychomycosis. And onychomycosis is something that's very common, and it is a benign, superficial, and cosmetic infection of the toenails and the fingernails. And most patients tolerate the tinea infection for many years. Patients who seek treatment, usually young adults, and they don't like the cosmetic effect of it. And the most common infection is the dermatophytic fungi, but the molds, the yeast, those may be causative agents as well. We see these a lot in patients who wear occlusive shoes. They work outside in the weather, and they get their feet wet, and they keep their boots on and their socks on all day. Diabetics get this pretty frequently, and someone who has participates in sports or has even poor circulation. It is more common in adults than in the elderly, and the toenails are more likely to become infected than the fingernails. Okay, so as we think about the treatment for how the patient presents with this, the typical patient who seeks treatment for this is going to present with like a thickened nail, or the nails have a cloudy white colored patch to them. Some of them report that the nail's discolored, and it ranges from yellow to green to brown to black. And some of them feel that their nail beds are or their nail is partially detached from the nail bed, which is called onycholysis. The risk of transmission is based on the systematic literature review, where 10 to 30% have a moderate risk of transmission in families, but low risk of transmission in schools. There's an incubation period about 2 to 4 weeks, and that is based on limited evidence. And then there's also been no recommended exclusion period from school, and that moisture and warmth promoting fungal growth. So this is some of the things that you see in the literature in regards to onychomycosis. In some patients, two types can occur simultaneously. So you may have a superficial infection that is more responsive to treatment with a topical antifungal than a subungual type. And then the superficial white onychomycosis involves only the nail surface, but can occur with either the distal or the lateral subungual onychomycosis. When the infected nail appears dry and has an opaque white patch with sharp borders that starts on the distal, lateral, or proximal surface, then it's starting to go deeper down in. As it persists, the nail gets brittle. The material that is made up of that hyperkeratotic debris then becomes scraped off easy. You can do a fungal culture on that, which they do at a lot of dermatology practices. And then in some patients, that white opaque area becomes discolored. That may be yellow, it may be brown, or even green-black color, which indicates maybe they have a pseudomonal bacterial infection. This is a good picture of a tinea corporis where you can see how there's central clearing, but there is elevated erythemic borders here. And there's multiple lesions, and some of them are small and some of them are big. So those smaller ones eventually would get bigger. And when they scratch those small ones and then they touch other areas of their body is when they're spreading those. When we're looking at corpus and curus, you can do the KOH preparation with the skin scrapings using microscopy. And as I said, they do that a lot in dermatology. The lab uses the KOH for diagnosis, but about 50% of the dystrophic nails are due to dermatophytosis. So they usually put a drop of 10% KOH on the sample of the nail clipping, and then they heat it with a lighter or a match. And the slide should not be placed too close to the flame, and then the KOH will boil off of it, and that heating exhilarates the effect of the KOH on that keratinized cell wall. So when the sample's ready, the hyphae will be easier to see because the cell walls have already been lysed by that KOH. They may also just do plain fungal cultures where they the samples are usually taken, and you get those results in like 3 days. The skin really should be taken from the active border of the lesion, and the nail sample should be taken from the subsurface of the infected nail. So these are usually done, as I said, in a dermatology practice. So some of the treatments, as we talked about, there's the topicals, which are very common. The topical treatment is generally not very effective when you're using them for onychomycosis. It's worth a try because you don't really want to have the patient have any serious side effects or have any liver enzyme elevation for it. But the good candidates for the topical treatment are usually patients who are very motivated to put it on. And this can be a problem. There's a topical solution such as Penlac or even Naftin that can be put on twice a day. And it can be effective when it's applied religiously to the toenails for at least 6 to 18 months. The fingernails 4 to 6 months. The problem is most patients are not religious enough to keep doing this type of therapy. And it is really only indicated for mild to moderate onychomycosis of the fingernails and toes. Initial improvement may take up to 6 months, but you may continue treatment up to 48 weeks with these. And Penlac is similar to a nail polish. You just kind of put it on like nail polish. Then there's the systemic therapy, for the patients who really want the treatment. That's the best way to go. The fingernails are easier to treat than the toes. The itraconazole, the econazole, the terbinafines, the butinafines. There's a lot of these that are listed in some of the other textbooks that you can look at, and in your own textbook as well as in Dynamed. Mentax is another one. These, though, you have to be very careful with some of these, okay? The patients who are on H2 blockers can take these medications, but there is no role really for the griseofulvin in the treatment of toenail because up to 80% will relapse with this drug. So griseofulvin is a medication that we used to use all the time. It was called Grispag, and it's just one that really causes so many problems with patients that we really have chosen not to use it much anymore. There's so many newer antifungals that you can use, so we've really gotten away from using those. The decision to treat it has to be considered. You really need to talk to the patients about this, explain to them the need for constant, meticulous application of these. And then you also have to let them know that if they're on any of these systemic antifungal drugs, because of the high risk of hepatotoxicity and liver failure, they have to be very careful if they're drinking, if they have a history of viral hepatitis, if they've had any type of cirrhosis of the liver. I would highly recommend not using these medications for that. And then there's a lot of drug interactions too, because these drugs are metabolized by the cytochrome P453A enzyme system. We call it the CYP450. And these, there are a lot of medications that interact with antifungal medications. Valium, Lanoxin, Halcion, Coumadin, some of the HIV drugs, and you just have to be real careful using these. I don't like to use them unless I have to use them. And this is just a picture of an onychomycosis where you can see the nail bed underneath turning that yellowish green color, and eventually this nail will probably lift. And we talked about the treatment with this, the oral antifungals, Lamisil, Sporanox. We already really kind of went through these, making sure to get your baseline liver function test as well as the CBC for any type of infectious process that could be going on. The next topic we're going to look at is tinea versicolor or pityriasis. Pityriasis is very common. It's usually asymptomatic. It's not associated with any type of itching. And the patient usually presents with an oval to a round, pink, hypopigmented or hyperpigmented macule on the back. It could occur on the chest. It can occur on the arms, sometimes on the neck and face. And more children are more likely to have it present on the face, especially on the forehead. But sometimes the scales are there and it's very difficult. This is characterized, this tanning does not occur in the affected areas. So a lot of times these patients will be out in the sun and they'll be tan all around them except in that specific area because it will not allow them to tan. It is basically a loss of the pigment of the skin. And this is kind of how it looks here. Versicolor is, as you can see, those little white spots all over the body. And you're tanning, so that since the pigment is lost, it's not going to be, the pigment can't tan. The tinea versicolor is treated with a couple different things that you can use. The topical selenium sulfide lotion, which is Selsun Blue, or can be applied 7 days from the neck to the waist, and then you lather it for 10 minutes before you rinse it on. It's kind of a shampoo, and it's a 2 to 5% base. The treatment is then done once a week for a month, and then once a month for maintenance. You also can use Nizoral shampoo, which is also called ketoconazole, and that is a 2% shampoo, which you put on the skin and you leave it on for 5 minutes, 1 to 3 times a day. This is usually the 2 treatments that might work, but you can't forget to tell them that it may not work. They need to be warned with the high rate of reoccurrence because this specific fungus is a normal inhabitant of the skin. So when you do expose that hypopigmented lesion to sunlight, it can actually speed up the process in some of the patients. So for patients who want more aggressive treatment, they may need to have the oral ketoconazole, which would be 200 milligrams a day for 1 week, or even 400 milligrams in one dose at weekly or monthly intervals. But it is not effective in preventing reoccurrence. That's the only problem. And then if these patients do decide to do the oral ketoconazole, they should be advised not to shower for at least 12 to 18 hours because that drug is delivered to the skin by the sweat after it's been absorbed into the bloodstream. And they need to be advised that there is a risk of hepatotoxicity, so they have to be very careful when they're drinking any type of alcohol, or if they have other superficial diseases or other diseases, which can cause them a lot of problems. The other condition in derm that I wanted to just briefly touch on was intertrigo, which is caused by candidiasis, and you may see this pop up in female patients. It is very it's in any area on the skin where the body has some type of a maceration just from that rubbing against the skin, and you see it in women a lot underneath the breasts. Where there's an increased heat and moisture, and so it can easily become colonized with candida. These areas include the axilla, the groin, under the breast, the perianal area, and sometimes they'll even get them intradigital between the fingers and the toes. And usually in some extremely obese patients, you may see it in other areas as well. But these are the most common places that you will see it. And they're mainly in an obese patient, and they develop that rich, red, itchy rash that is weepy and it's moist, and it can cause secondary infections. The treatment for this is just to really keep the area cool, keep it clean, keep it dry. topical antifungals, and if it's really moist, use that Burroughs solution compresses. One of the things that I do not recommend is that you put baby powder underneath these areas, because baby powder, once it gets wet, it kind of gets real gummy, and the fungi love that type of a moisture and that type of a clumpy medication that it can just get in there and just harbor. So be real careful when you're giving these patients any type of powder underneath it. It's just not a real good idea. The yeast produces azelaic acid, which diffuses down and impairs the function of the melanocytes, and that's basically what occurs here with these patients. Teenagers and young adults are affected most often, but they're really more seen in if they're obese, teenagers, obese adults. It is not frequently seen in the geriatric population unless they are an obese person, and then you probably will see that. The Candida albicans is the most common of all the yeast. It's about 60 to 90% of all the yeast infections that you see. And now we're going to look just very briefly at parasites. So as we look at head lice and we look at scabies, um, the pediculosis, which is the infestation of head lice, has been documented for a long, long time. We all dread it when our kids go to school and our kids come back that first week and we're checking their head to make sure that they don't have any lice. And then that, infestation starts to occur in the school systems. There's only 3 species of lice that are known to infest the humans, and it is the crab louse, the head louse, and also the body or the clothing louse. So lice infections occur in people of all ages. Head lice, very common in children, school-age children. Pubic lice, most often seen with sexually active adults. And children aged 3 to 11 are most commonly affected, with that occurrence being more in girls than in boys. The body lice, as we call it, are increasingly rare in the United States, but can be seen in communities of people who are homeless. They have improper hygiene, they don't launder their clothes well, they don't vacuum, and so they're living in crowded conditions, and they don't have the ability to keep the place clean or to even wash. And they're really the only lice that are associated with disease transmission. Infected feces of the body louse can transmit and cause trench fever and relapsing fever. So it's not a real wonderful thing for someone to have body lice. The pubic area, usually we put nicks on that area and other things to apply to the body, and there can be washed off in 10 minutes. But some of these are very caustic treatments, and you have to be very careful with the management of them. The treatment involves both medication as well as the environmental controls, and it's important to screen all the close contacts for head lice, keeping in mind that they may be asymptomatic and have a very small number of live lice, but you still need to treat them because you don't know when they're going to go full blown. They need to be reevaluated after a week, and if the live lice are still present or if the nits are seen close to the scalp, then you have to do another treatment on them. So the initial management of patients who are diagnosed with this is directed at killing or even removing the nits and the lice as well. So there's shampoos, there's cream rinses that contain the permethrin, the lindane, the pyrethrin, the malathion, and they all are used. And you have to be very cautious with these because they can be toxic, although lidane is probably the most toxic of all of them. It is rapidly absorbed through the skin. It's been associated with central nervous system symptoms such as irritability, seizures, and overdose. If somebody has overdosed with it because they've ingested it, death can occur. It should not be used on older patients or any patients with a history of seizure, and anybody who is pregnant, nobody who is lactating. So that's one of the drugs that you may want to kind of stay away from. When you're manually delousing and removing these nits, you need to use a fine-tooth comb, and we've all probably done this on our children in the past. You need to treat the clothing. You need to, do the laundry, make sure you're using very, very, very hot water. And eyelash infestation can be treated by putting petroleum jelly to the eyelid margins twice a day for 10 days. And if the eyelash is infected, then they can also be treated with physostigmine ophthalmic solution, or it's like an ointment. And it's a 0.25% to a 1% twice a day for 8 to 10 days. And this treatment can cause eye spasms in the younger adult. So, but the lice and the nits should also be manually removed from the eyelashes. So, they'll just slide right off those hairs once you put that petroleum jelly on them. We usually try to recommend a follow-up in 1 week to make sure that all of them are gone. And scabies, very similar. Scabies are a pain also. They are highly contagious, and we all know that. They occur mainly in young adults, children, healthcare workers, institutionalized people. The diagnosis is easily missed and needs to be considered if there's persistent and severe itching. And I remember one time as a nurse, before I was a nurse, and I was a nurse's aide, and I carried some bed sheets from a nursing home into the laundry, and the next thing I knew, I had scabies on my chest. So you have to think about those things when you're changing linens, when you're changing patients' clothing, not to put them up against you. It is caused by the itch mite, and the scabies infestation is definitely worldwide. It's an epidemic, and so you have to be very cautious when you're working with patients. Close personal contact is your major mode of transmission for scabies, and institutional epidemics have been reported in which caregivers have been infested. So these live mites have been discovered in dust samples from the homes of infested persons, suggesting that there is a fomite transmission as a possibility. These patients usually present with complaints of intense itching, and it's usually described as being more severe at night. The itching could be widespread, but it's commonly located in the intradigital web spaces, in the wrist, in the anterior axillary folds, the periumbilical skin, the pelvic girder, the penis, the ankles, and many patients may develop a rash where others may have, itching for months and have no apparent rash at all. So you have to be looking at that too. The parents are usually aware of similar symptoms in family members, and then sometimes that light bulb goes off and they're like, oh no, we've got a scabies infestation here. The earliest physical signs of scabies are small red papules located in the area of the body that are the most attractive to mites. And because of the intense itching and that constant scratching, repeated scratching, and the crusting and the scaling, those are some of the things that you're going to be looking for when the patient comes in complaining of itching. It can be difficult to visualize the mites on the skin, so it's really hard to see these. But the itching is due to that hypersensitivity to mites as well as to the products history. Papules, burrows, erythema, all of this pay real close attention to. The first thing I do when a patient comes in and they're telling me I've been itching like crazy for a long time is start looking all over their hands and their axilla and their interfolds of their arms. And each female mite produces one burrow. So in light-skinned people, the burrows have like a whitish color that you can see with a black speck, and that black speck is the fecal particles of the mite. The female mite resides at the blind end of that tunnel, and she can actually burrow about 2 to 3 millimeters a day. So the burrows are usually distributed in areas where there are very few or no hair follicles at all. So keep that in mind when you're doing your exams on your patients. And there really isn't any diagnostic testing for these. You could do a burrow ink test, which can easily be performed, and you would rub a felt tip pen over the suspected burrow. And if you use a blue and green marker, that would work best because they don't interfere with those microscopic results. And then you can remove that excess ink with the alcohol wipe. And the remaining ink concentrates down into the tunnel, and you can see the actual burrow when you're doing that. Once you've located it, then you can put mineral oil over it, scrape off the burrow using a scalpel blade, and the scraping should be placed on the slide, and then you can look to see if you can see the scabies there. If you can't identify the mites, then it does not rule out that there's not any scabies infection, unfortunately. If it's suspected, just go ahead and treat them. So proper adherence to treatment, the cure rate is 100%, but you have to be diligent with this. And if anybody's treated their children before, they do know it. So the initial management of this patient is killing all these live mites. So using lotions containing the scabicides, the same thing really that you're using for the pediculosis, antihistamines, topical steroids, making sure that you think about the CNS symptoms because of they're the same as with the pediculosis also. Using the Elamite cream, neck down coverage at night, repeated in a week. Make sure not to get it in their eyes. And treat everyone in the household. Wash your clothes in extremely hot water. Wash all the bed linens. Vacuum your furniture. Vacuum your rugs. And bag things that cannot be washed for a week. The mite resistance has been reported with the Elamite. It is safe for use in children 2 months and older, and you may have to repeat the application even a third time in a week if you're still seeing those. And this is just a picture of a burrow where you can see the scabies is actually burrowed down, and you can see the darkened areas here that we were talking about.